We've got Debbie Widdowson and Yvonne Allen. So Yvonne is our local CQC officer. So you may well see her, and some of you may well have already seen her in some of the areas with me walking around. So you will see more of Yvonne going forward, because it's about building that relationship. So I'll hand over to you.
Thanks.
Okay, thank you.
Hello everybody. I do recognise some faces from when we came and did the inspection. It was about 18 months, 2 years ago, wasn't it? So it's nice to be back, and thank you all very much for taking some time out to come and listen to us this afternoon. The presentation is really about two bits. It's about sort of explaining our strategy going forward, where we've been, where we're going, that sort of thing. And then Yvonne's going to follow up at the end with a sort of a, well, what does this mean for you kind of thing. So hopefully by the end of the presentation you'll sort of see that we're going to change tack slightly. We want to develop something that's more of a continuous process, and you'll be able to see what your role is within that. So anybody, if you ask anybody that ever goes to a CQC inspection, they always start off with this slide, which is about the purpose and what CQC's role is. And it's always really helpful to remind people actually what we do and equally what we don't do. So we are an independent body, although we're sponsored by the Department of Health, we're actually an independent organisation. So that means that we're independent of all the politics, which is quite apt at the moment, isn't it? We are a clinically driven organisation, so our main focus when we come out to look at services is about quality and safety. That's what we're interested in. We're interested in the patient experience, and it's really important that we put that patient's experience at the heart of everything that we do. Hi, come on in, take a seat. We're more about evidence-based judgments and less about compliance. So those of you that have read the reports and read your report from last time will know that it's based a lot on the evidence that we collect, not just while we're on site, but during the lead up to and after the inspection as well. And we're also an organisation that prides itself on being as transparent and open as possible. So all of the tools and everything that we do are all available on our intranet. There's no secrets, there's no hiding. All of our key lines of inquiry and everything are out there. And we know that organisations are now using that and developing their own internal systems of audit, and I know that you're doing something similar here. And that's really what that purpose is to help drive improvement, which is sort of the last key point I wanted to make, really. A lot of people think that CQC are about finding bad practice and pointing the finger and telling people, putting them on the naughty step. But actually, we're just as much about identifying areas of good practice, celebrating those areas of good practice, and also driving improvement as well. So, why new strategy? You all work in healthcare. I don't need to tell you that this is a hugely changing environment. We're seeing very innovative and quite creative models of care coming into the healthcare sector now. We're seeing more collaborative work with other agencies such as social care. So it's a changing and an adaptive environment. And as a regulator, we need to make sure that we are still delivering something that is credible and meaningful to the people that work within those services, as well as the people that are in receipt of those services as well. So it's estimated by 2020 that about 50% of the population will be receiving care in one of the range of these new ways of working, with bits of organisations working together, new organisations being organised, and so we need to respond to that. Like any other public body, we need to watch our resources and manage our resources as well. So that's another key factor for us. And also we want to make sure that the people that have a stake in what we do, so that might be the CCGs, the public, people like yourselves, still consider what we're delivering is valid and credible to healthcare. So our ambition over the next 5 years is to deliver a more targeted approach, to be more responsive, to work more collaboratively, and also to make sure that we continue to ensure that people get the high quality care that they need. Our 4 strategic priorities in order to get to that are, as I've already said, about continue to encourage improvement innovation and sustainability in care. And I think sustainability is becoming increasingly important, don't you agree? Actually finding models of care that not only work now but will work in the future is really important. We're trying to develop a more intelligence-driven approach to regulation. So I don't need to tell you how much data you probably collect on a daily and weekly basis as part of the work that you do. And we feel, let's try and reduce some of the inspection burden by trying to harness some of that, trying to collect some of that, and share that with other stakeholders and other people that are interested in the intelligence, to reduce the burden on yourselves, but also to make sure that we are being consistent in some of the things that we're looking at. We want to promote a single shared view of quality. So for you guys, you've got the CCG, you'll have NHS Improvement, you'll have us, you'll have other regulators, some that are specific to the areas that you work in, like your professional bodies. And I guess from where you sit, sometimes it feels like that the way that they describe quality is all slightly different. And what CQC want to do, one of our ambitions, is actually to drive forward so that we have a common shared view of what quality looks like. What does good look like? And that we all agree on that, including yourselves as well. Wouldn't that be really good? Wouldn't that feel much better than having to answer this person with this piece of data and answer this one separately? Wouldn't it be nice if you could have one answer to one question that all of those individual organisations would be content with and happy with? And finally, as I've already said, as a public organisation, we need to improve our efficiency and effectiveness. We've all seen, I'm sure you've all seen the news reports about the huge teams of people that turn up on inspections. I think we had about 30 or 40 people came to inspect this trust. We've been on inspections where we've had over 100 people turn up. We need to use our resources more wisely. We need to be smarter about that. Only in the same way that you guys have to do that as well. It's exactly the same principle. So, when will we know what? Well, we'll know we've succeeded when. So people trust our independent judgments and use our expertise about quality of care. So how we measure this is if people read our reports, but also about when people come to us because they trust us with the information that they have. So the more members of the public that come forward with their stories, good and bad, the more members of the public that pick up our reports when they're thinking about care and treatment, is a really good indicator to us that what we're doing is working. People have confidence that we identify good and poor practice, that we will take action where necessary. So that's about using our enforcement powers effectively, things like warning notices, things like taking enforcement action around regulation. We need to use those smartly and wisely and make sure we get to where we need to be in terms of the quality of care. And also when we identify good care, that we say that it's good. Now you know as well as I, the Daily Mail aren't interested in the good news stories where a service is really good. But when it's really bad, they lack a nice juicy story like that. But we will continue to make sure that we publicise around good and outstanding services as much as where services are poor. It's really important because within the health service, you want, if somebody's doing it well, something that you need to get better, you want to know who's down the road or at the other end of the country that's doing that. And we can only do that by publicising it and writing about it in our reports. And finally, organisations that deliver care improve quality as a result of our regulations. So we want to see improvements driving. We want to see overall ratings going upwards, not down. And we also want to encourage organisations to use their resources as efficiently as possible to deliver high quality care. What's going to stay the same? Our purpose, which I recapped at the beginning of the presentation, won't change. Neither will our role or our operating model. Our inspections will continue to be at the core of what we do. We're not going to be changing that. Nor will our work with the public, working with organisations like Health Watch, and as I've already alluded to, encouraging the public to come forward and talk to us and share their stories with us, and also our role in protecting and promoting equality and human rights. All of these will stay and they will all still continue to be an important part of what we do. So what we'll do differently. So we're going to be supporting new ways of working by providing, so for those providers that are delivering care in different ways, we're going to look at how we can inspect them, adapt and change the way that we do that so that we can tell the right kind of story and we're not trying to put square pegs into round holes and vice versa. We're going to focus more on the quality of care for population groups. So we're starting to pilot something that we're calling place audits. So this is where we're going to be looking at an entire location, an entire population, and that inspection will cut across acute care, primary care, social care, so that would include the GPs, the dentists, all the care homes, district nursing, acute care, the whole lot within a given population. And that's really exciting. That's something that we've not done before on that kind of scale. Those pilots are going to be starting quite soon, and it would be quite exciting to see something like that, especially, say, for the county of Shropshire, for example. We'll also be rating how well NHS trusts are using the resources. Now, as I said at the beginning, CQC's role and remit is around quality and safety. So we're not going to run out and employ a whole busload of accountants because we've got to manage our resources, we can't afford that. And neither are they going to send me to accountancy school, thank goodness. What we are going to be doing is working much closely with colleagues at NHSI who have more of a clear view on use of resources and that side of the business. And they're going to be doing that piece of work for us. We're going to be working more collaboratively with those. And then the ratings will come out of a process of talking to them. So we're about to pilot some of that work. You may have already read about that on our website. But we're going to be trying out the methodology around that, how we're going to rate around resources. But that's not something that CQC are going to be doing themselves directly. That's going to be something that we're going to be doing in partnership with colleagues at NHSI. We're going to focus our resources towards high-risk applications at registration. I'm sure you've all read lots in the paper about difficult services, where service users are not getting the best kind of service. And we see that registration is the gateway to that. So particularly around independent healthcare, we're going to be much more stringent, we're going to have some much tighter and be much more risk-based in the way that we register those services. And that's really important. Bearing in mind what we were saying earlier about the new models of care coming through, we need to make sure that those new models are as robust as possible, and registration is one way of us doing that. And finally, we're going to build and use our insight to target our inspections where risk is greatest. So that's about building an intelligence model. Somebody much cleverer than me, who with a brain much bigger than mine, is sat somewhere developing some very technical. I'm sure it's more than a spreadsheet, but I'm just showing my ignorance now, aren't I? Some sort of system whereby we can collect all the data together that we have. Data that you collect, data that CCGs collect, data that NHSI collect, from STICE, from all sorts of places, and pull all that together and actually have an ongoing process of intelligent monitoring of what's going on in the service, drawing all of those things together. So some of you, no, you don't look that tired actually, so you might not have been involved in the data collection exercise when we came last night. Oh, I can see some signs of recognition. You know, the reason we used to give you 20 weeks notice is because it took that long to get all the data together that we asked you for. And it was quite tedious and it was quite arduous and it was quite a long, protracted process. We want to move away from that. We want to make it a more ongoing process, so it's less tortuous for you and less challenging a process, so that data is there real time, more or less all of the time, and that's what we're aiming for, that's what we're trying to strive for. We are going to be asking providers to describe their own quality against the five key standards. So, I know that you've been doing your own internal reviews based on our key lines of inquiry in the 5 domains. That's great. Like to see more of that, please. And that's what we're going to be asking you about the results of some of that work. So I hear the phrase mock inspection a bit. as opposed to, which makes it sound it's a bit fake, but I know what you're trying to say. Doing your own internal inspections, and for those of you that are leading teams within the organisations or heads of departments, using our key lines of inquiry, using the domains, is a really good, simple tool, and it's been tested, so you know it's robust. A way of actually measuring quality, about actually looking at the way that your governance is operating within your teams and within your areas. And if you feed that up through the organisation, when somebody like me comes across and sits across the table from Mark or Bev and says, right, how are you doing? You're able to describe it in the CQC language, which makes that communication, makes that conversation easier to understand, because you understand the domains and the key lines. We're talking the same language. Really very simple, but really, really helpful and really important. I talked about sharing data sets as part of that insight model. We're going to be moving as much as we can do as online. This isn't so much of an issue for NHS, but I do know that there are some care homes in the area that still don't have internet or computer or whatever, so we want to try and move everything more towards being internal, and actually invest in our own internal systems to make sure that we are working as efficiently and as effectively as possible. So, I thought at this point it might be really good to recap and let you know what me and my teams of inspectors have been doing for the last 3 years, 4 years or so. And so over the last 2 years, we've inspected every single NHS trust in England at least once. Some of them we've been back to more than once. So over the 2 years, we've done 97 acute trusts, 14 specialist trusts, all 10 ambulance services, 11 community trusts and 58 mental health trusts. That's why I look so tired. I've not done all of them myself, but it feels like it. And this is the rating. So remember I was earlier saying about driving improvement and seeing change and seeing development? So this is the percentage of overall rating. So you can see about 2/3 of trusts across all of that group were rated as requires improvement. So, and about 1/3 to 1/4 of those are rated as good. We've got 4% that are outstanding and 12 that were rated as inadequate. And we had quite a number in special measures. Some have improved. Some of you might have read the papers recently and know that some have gone back in, some have moved out. It's a moving feast. But in essence, what that means, those trusts coming out of special measures, mean there's about 5 million people that are now receiving better care of the regulation that we do. What's really interesting, and I don't think I've got a slide on it. No, I haven't. What's really interesting, and if you have 5 minutes, or you may have already read this, but we've got a report on our website called State of Care Report, which summarises everything that me and all the inspectors have been doing over the last 3 years. And although within that, what it shows you is, although 2/3 of trusts are rated as requires improvement, actually because of our aggregation system, 2/3 of core services are actually rated as good. So we're seeing some really good work. We're seeing that there's lots of good services out there. Patients are getting some really good care. But what we want to see is we want to see that those two boxes switch around. We want to see more good and the numbers of requires improvement going down. And this is how we think we're going to do it. So we're going to focus more on those core services that require improvement. So we're moving away from a comprehensive inspection. So next time we inspect a hospital, we will not be looking at all the core services every time that we come. We're going to be separating out some core services where to ensure that the focus is appropriate. So last time, for example, here we had a core service that looked at outpatients and diagnostics. We're going to separate them out. So we will look just at outpatients, but if it's a hospital where we think diagnostics is significant, it's something that is a big enough service, then we might inspect it separately. So we're going to be separating out the core services to make it seem more meaningful. And for those of you that work in outpatients and diagnostics and have tried to read one of those reports, it feels a bit like two in one, trying to tell two stories with one report. So we're going to be separating them out. So we will be updating the ratings based on smaller, more focused inspections. So if we come back to, if a service has got 8 core services and we only inspect, say, 3 of those, the 5 ratings for the other core services will stand until we go back and re-rate. And just tucked onto the end of that sentence there, you might notice it says, use more unannounced inspections. You will not get 20 weeks notice next time we come to inspect. You might not get any notice at all. We might just turn up.
And it will be Yvonne.
No, I'm joking. We feel... those of you that have been in the health system a long time and are used to regulation, I've been doing this for 12 years now. We've done lots of unannounced in the past, and we've announced, and now we're moving back to unannounced. And the reason for that is 2 reasons. First of all, the public like it. The public prefer it if we go unannounced. They think it's cheating, giving you 20 weeks notice. You know, and you know, if you ask any inspectors, it's lovely when I come round and everything's lovely and clean and tidy, and all the notice boards are all, you know, in straight lines and everything. But that's not real life, and we need to see it as real life. So that's why we're moving more to unannounced. Or it might be short notice. So we might ring you up, say, hi Mark, we're coming in a fortnight's time, whatever that might be. We're not coming in a fortnight's time. Don't write it down. You are now. So we're moving much more to unannounced and more short notice visits. We're going to introduce an assessment of well-led at trust level. So those of you that have read the previous report, you will see that we rate each individual core service and aggregate that up to a rating. So of the five core services we inspected here, thank you, we will add up all of the scores for well-led across those 5 and give the trust overall a rating for well-led. But actually that doesn't always work, because we're taking local leadership as a proxy for executive leadership, and actually we should be looking at them separately. So that's what we're going to do. So after we've come and done an inspection on the core services, at some point, maybe a month or 2 after that, but this will be announced, so you'll know we're coming, so you can't book a holiday. We will come back and we will do a separate assessment of well-led, which will look at leadership at executive level and at senior management level. And the core services will just continue to look at leadership as a local level. So it might be that the core service well-led aggregation comes to 1 rating, but if we look at it at an executive level and a senior management level, that rating might come out as differently. And that again is quite a different approach for us. And also, we're going to produce shorter reports. Yay! Our reports are really long. Really, really long. They're long to read, they're even longer to write, aren't they? Yes, yes. So we want to move to more shorter, punchier reports. We're testing out different models, maybe with an appendix with all the data in, just some prose at the front, or just go into executive summaries. We've got lots of ideas, lots of models that we're trying out, but we want to move to something that's more shorter, much punchier, much easier to write. Okay, so for the last few slides, I'm going to hand over to Yvonne, and then when Yvonne's finished, if you've got any questions for us, we'll be around. If you want to talk to us one-to-one as well, we'll be around. But Yvonne, over to you.
Thanks very much. Is that one? All right, thank you. Hello, everybody. So I don't think there's a great deal of change here, if any change. Outstanding, good, requires improvement, inadequate. Outstanding is performing exceptionally well. The good is the service is performing well and meeting our expectations. Requires improvement. The service isn't performing as well as it should, and we've told the service how it must improve. And inadequate, of course, for performing badly, and we've taken action against the person or organisation that runs it. And based on that, we come out and inspect. If you're outstanding overall, you'll be inspected every 5 years. If you're good, it's 3.5 years. If your requires improvement, it's 2 years, and 1 year for inadequate. There's not a great deal of change there. That was your trust ratings grade 6th to 8th of October 2015. I know that you've been working on that action plan a lot, and you've been giving us information about how you've improved, and you've recently had that signed off, I believe. So that's good. So you can see where we may come and focus our inspection activity on the requires improvement section. So there's a few of those dotted around that were there then. Okay. So, how will we carry on our inspections? What's changed? What will I be doing now that I wasn't doing last year? I'll be doing things differently. I'll be coming out more. I'll be using CQC Insight, which is a tool we use to gather evidence. And we'll have a dashboard available. I think we've got a dashboard now coming in this month to see how our trusts are performing. So we'll have that information, that intelligence ongoing evidence gathering through the year. Also our stakeholders that Debbie has mentioned previously. I'll be coming out meeting staff. I'm definitely coming out once a month to meet Bev. I shall also be making other arrangements to come out and do staff focus groups. So this is your opportunity to meet with me and tell me what you're proud of. Tell me where it's good. Tell me what you think was good last time and where you think could be outstanding this time. So it's definitely your chance to tell me. So there'll be a lot more of that activity, which I think is good. You know, so I'll really know you really well by the end of the year. And you'll know me well. You might not like that, but you... And it'll be surprise, it's not filler here. But it might be that I come out and do unannounced. We'll see what happens. But we've been certainly, as Debbie mentioned, making great use of the unannounced inspections. Short notice inspections, 4 to 6 weeks. And again, as Debbie mentioned, inspections of selected core services, plus the annual trust well-led inspection. The CQC team size will reflect the shorter, more succinct inspections, so it won't be a great big crowd and a busload coming. And again, yes, more shorter reports, which all the inspectors are grateful for. So, any questions? It's that time of questions, so we'd like to take any questions. Thank you for listening. Has anybody got anything they'd like to ask us? Hi.
Can I ask a little bit about comparative information between trusts? Because I'm really confused looking at other boards, how they measure things. We just don't have much consistency in the NHS of measuring things. So take safety, for example. We're about to see a new safety dashboard come out from NHS. It's got a new acronym. You know, where did that come from? How comparable it is? What is it benchmarked on? And how does it replace NATSIPs and other things? You know, there seems to be a lot of prangos doing different things, and it confuses me.
Do you want me to? I agree with you, actually. I think it is quite confusing, and I think that's one of the drivers that we've got actually for developing this insight model and developing this sort of one encompassing continuous data gathering and data management process. And it's particularly challenging, I know, for specialist trusts such as yourselves when it comes to comparative data. So we're mindful of all of that, and we've learned a lot over the last 3 years about the way that we collect the data, the way that we compare, and with the way we manage that. And that's why we move into this new model, this new insight model, that won't eradicate all of those problems, but we think it will be a better fit. And sort of moving towards having a more ongoing, continuous approach to data collection, rather than it being a once a year, because that's the other challenge with comparison, comparing somebody in January is not the same as comparing somebody in July, is it?
No.
So we need to make sure that we're consistent over time, that we're consistent, you know, we're not comparing apples and pears, as they say. And we believe that if we build this model in the right way, and the early signs are that it's going to work quite well, isn't it? We think that will help with some of that. And that will all be shared with stakeholders, so you can see some of that as well.
That's good. Thank you.
You're saying it's going to be shorter visits. What's the shortest visits? Just unannounced? Or?
Could be a day. It could even be out of hours. We could come on a Saturday morning or calm down.
You can't come Saturday, watch his football.
He doesn't have to be here. The unannounced visits can be a day, maybe a day and a half, something like that. The actual site visits themselves, we're going to make them short. If we're doing things like focus groups throughout the year, if we're doing data collection throughout the year, if Yvonne is in and out of the trust and collecting all of that evidence and all of that intelligence throughout the year, actually we will have done a lot of the work before we actually get on site, so there's very little for us to do if the trust is engaged with all of this and we're very minded. A lot of the times our experience has shown us over the last 3 years when we've gone to do these inspections, you're not turning up cold, but you're not as familiar with the organisation, so you're spending a lot of time actually familiarising yourself with it. If Yvonne is able to achieve all of these things, actually we can almost hit the ground running really, so that takes up less of your time, takes you away from the patients a lot less and makes it a more focused approach, which is what we're aiming for.
Sure.
Hi. You mentioned before that you're separating outpatients with diagnostics.
Yeah.
What benchmark are you using for the diagnostic side, if you've never done that before? Would anything be different from our last visit?
No, I mean in terms of inspecting and reporting.
Yeah.
So what we've done up till now is inspect and report and rate outpatients and diagnostics together. What we've found again over the 3 years that we've done, we've actually found, and it doesn't apply here, but maternity and gynaecology as well were together. And what we'd find within these services actually, if one half of it was really good and was a good rating, and one was an RI, actually it was, to be blunt, dragging the whole service down. And that's unfair, especially if you're the one that's good. I'd be right cheesed off.
Yeah, because on the thing that you showed before, it was, we had like most of was required improvement, and I personally didn't see much feedback as to which areas to focus on. So if you were to come again, I'd like to address that beforehand.
Absolutely,
so
absolutely.
Information available like we get from.
So we'll be able to inspect and report and rate separately, so that you're very clear and very focused on the bits that apply to you, very clear and very focused on where your areas of improvement are. And also, it's very clear what you're doing really well, and that we can explain that to the patients and explain that to the wider world. And you'll be getting phone calls from other trusts saying, tell me how you do that, how you manage to get an outstanding or whatever it might be. So that's I always say outstanding. So that's why we've separated it out. But if you read the reports, it's very confusing because you don't know which applies to which, and if you work in that service and you want to know, it's really difficult. So that's why we've split it out.
I've got a couple. So thank you, really helpful, really helpful. 2 questions really, and they're specific to us, I suppose. So the first is, and this is me making a plug, of course. You'll be aware that we have come top first in the PICA inpatient survey this year for our inpatient care. That's embargoed at the moment, so we're only allowed to say whether we've done very well in it, but we've come first, which is amazing. What I'm struggling to understand is in what you were saying about reassessing, on our,
This one?
So, for example, there's obviously a strong link with caring there, for example. So 2 parts of my question. One would be, is there any danger then that you will take our caring as good and in effect not reassess it, so we couldn't potentially be outstanding? So that's one question.
Okay.
And the second is is it, if that was the case, is it really possible to look at caring without looking at safety? Because the two things are so intertwined. Does that make sense as a question?
Absolutely, perfect sense. So, when we talk about the aggregation ratings, we're looking at, I've been dying to use this as well, so thank you. This column, this end column here, which is the overall score. So if a core service, as Yvonne quite rightly said, if a core service is rated as requires improvement, we need to come back to inspect that within 2 years. Just 2 years, yeah. Within 2 years. And if it's good, we'll come back and inspect within 3.5 years. So that's the core service across the overall. So let's take, for argument's sake, the top one, medical care. We may say, at our next inspection, we may say, right, we're coming back to look at medical care. And we'll say, right, do we want to, and we will probably reassess all 5 domains. So when we're talking about the ratings, we're talking about the core service outcome, not the domain rating. Now, it may be that it takes, if you get 2 outstandings, you're outstanding overall. So it may be, let's say for argument's sake, next inspection, we come back and inspect medical care and critical care, nothing else. But you get an outstanding in care for both of them, you will end up with outstanding here overall because the rest is good.
Yeah.
So just inspect it, and that's what I mean about the ratings rolling over.
Just to clarify, I'm just trying to understand it. The thing here, though, is, because we're not a DGH, of course, so where I was before, you've got half the hospital's medicine, half the hospital's surgery.
Yeah.
Here, 90% of the hospital is surgery.
Yeah.
So there's a kind of, I think it's, and by the way, our medicine is brilliant as well. And you'll
I'll just write that down, Mark.
made major improvements in that. But in terms of the balance, is there a risk for us then in terms of the process, I suppose?
Well, let me say 2 things. I absolutely agree with you, and I think one of the things that we've acknowledged over the last 3 years is not all core services are equal. So let me try and think of an example. A typical DGH, you're right, medicine and surgery are really big, and then you've got your children's services and you've got critical care. But all of them carry equal weight in terms of the rating and aggregation, and we recognise that. And that's part of why we're moving more towards this focused approach. So what's going to happen over the next year or so as you're working with Yvonne, and Yvonne's starting to understand the organisation and work out where's good, where the issues are, is as part of the process of working out where we're going to come and inspect. Because by our rating rules, you've got 4 services there that requires improvement, and we've got to come back within 2 years. So we might say, well, we'll do 2 this year and 2 next year. If we decide that, there will be a dialogue to be had between you and Yvonne about which core services do you want us to come and look at. Which ones do you think you've made the most improvement on, or which ones are we most worried about? And that's a conversation that we need to have.
But would that then mean that you wouldn't intend to come back and look at our surgical service in the same time frame?
Might not be, yeah.
So my argument there would be, you're therefore only looking at 10 or 15% of our business.
Yeah. And that's why.
And I would argue, even though it was good, I'll be brave here. Bev might kick me afterwards. I think there is considerable outstanding stuff in surgery.
Great.
So in terms of improvement,
yeah,
we would want you to come and look at that for 2 reasons. One is it's improved, definitely improved, as the other areas have too. But secondly, actually, in terms of a sense to patients, particularly and staff of the whole hospital, if you come back and only look at the others and don't look at surgery again, I don't think you're actually looking at the whole hospital. I think you're looking at, say, just to use my numbers, say 15%.
No, you're right.
Which then doesn't kind of pass the sniff test. It doesn't make sense.
You're absolutely right. And this is the challenge that we've got with the hospitals, much bigger than yourselves. No disrespect.
I can't believe I'm lobbying for you to come back and look at more areas.
I can't.
Which is what I'm doing.
I can't believe you're actually saying this. This has never happened to me before.
But it doesn't. It just because of it's particularly with the nature of what we do. That's why I'm struggling with it.
And this is why, because we want to move more to this more focused approach. This is why we need the inspectors, i.e. Yvonne in this case, to have this ongoing relationship, to have this ongoing dialogue. so that when we come back, we know we're looking at the right things at the right time. That's the really, really important bit, because we don't want to get to, and you remember the early slide about our key ambitions, how we will know when we succeed. The last thing we want to do is publish a report and the public say, well, that's a load of rubbish because they've not looked at X, Y and Z. So it's really, really important that we have this ongoing dialogue, that when we come back and we say, and we knock on your door and say, morning Mark, we're here to inspect and we're going to look at this, this and this, and you go, grand. Because we've had that dialogue, we've had that discussion, we're clear where we think the risks are, you've explained to us where you think you've made most improvement, and then we inspect accordingly, because we don't want to hamper your services by inspecting the wrong things. We want to get the right messages out to the public that if you're doing really well, we want to be able to say you're doing really well. But we from a resource point of view, we don't have the resources to come back and look at every single core service every single time. So we have to be careful, we have to be smart, and we have to work together to make sure we pick the right ones.
So that'd be a good debate, won't it?
Yeah.
So thank you for
Yeah.
that. So second thing, slightly technical question, but it's very relevant to us at the moment. So, as you know, we're in breach of licence at the moment. So NHSI have begun the process to remove the breach of licence. We're on breach of licence for two reasons, so for governance and for RTT. Because of the TDA and Monitor coming together, that process is a fairly new process.
Yeah.
Whilst we understand that decision will be made at regional level, I think realistically, even if they may take some of the undertakings off us this month and some the next month and some in July. My question is it possible overall to move from segment 3 to better than segment 3 if we're still requires improvement? So, in other words, if you were to come fairly soon and look at us, we could still be in breach of licence technically, although the process had taken us off and all the evidence is there. So I'm trying, because I'm arguing with them at the moment to say, unless they get their act together, because they're saying you should, basically you shouldn't be anymore, it's the process. There's potentially a double whammy for us,
There
really.
is,
Do you know what I mean?
I do, yeah. The short answer is I don't know. Because that will be about NHSI's methodology and the way that they're going forward. I certainly know it's something that they're thinking about as part of looking at the pilot work with the use of resources rating, because that's certainly something that has been asked. One of the things that we've had feedback on is the inconsistencies between what we're saying and what NHSI have said in terms of you've got to do this with your resources, and we're saying you've got to do this with quality, and it's a challenge. So a lot of the work that we're doing now is actually bringing those things together. I don't know enough about the technicalities around it.
Because one of the things I think I'll stop this.
No.
One of the things I think was good when you came last time was the trust wasn't in breach of licence when you came, and actually the report was, and I mean this in the very kindest way, the report was retro-written to reflect the fact that the trust then went into breach of licence. And I think for all the reasons you said before, I would describe that actually as triangulation of data. I think that was good. That was a really good example of the CQC and Monitor then actually saying, hang on a minute, this has got to make sense all round. So it requires improvement and it's breach of licence. And that was absolutely right for where the organisation was. My anxiety is we don't get the benefit of that in effect. That triangulation process, we get potentially a kind of double whammy at the other end of it, where if the things aren't synced together, that potentially we don't get. So let me ask you something you might be able to answer then. Is it possible for a trust in breach of licence, if we were, to get better than requires improvement?
There is nothing in our methodology that influences the rating on if you're in breach of licence or not. So the way that we make assessments on your rating has nothing to do with that. It's purely about what we find on the inspection, quality and safety, and how you fit the characteristics. The characteristics are a published document, you can find them on the website. There is nothing in there about breach of licence. So it'll be what we see at the time.
Right, that's good.
So it will, and also, you can be quite critical of the inspections because we inspect at a certain point in time and we report what we see at that certain point in time. But also what we try and do is actually, we do want to look at sustainability, we do want to look at going forward. So, for example, where an organisation has had problems in the past, they're trying to fix it, they're not there yet, but we acknowledge that they're trying to fix it. That is what we were reflecting in the report, not, oh, that's terrible over there, and full stop. You know, we try and look forward. But there is nothing in our methodology that would stop you going from alright to good around your breach of licence. It would be around a patient safety issue, around a quality issue for you to not get that.
No, that's really helpful, thank you. It's complex, this stuff, but it's...
Yeah.
I want to try and... I've asked you this in front of the staff, not to catch you out.
No.
Because it's the kind of conversations that we're having about, well, how good could we be? What is the level of our ambition? And if that is, and Nikki's question was a good one, you know, what the underpinning things, the level of detail that people like Nikki and Eric and others in their areas, a good example, would really want to understand on that journey.
I would say my advice to you would be to go on the CQC website, pull off a document called characteristics. Is it rating characteristics? Is that what it's called? And it tells you under each of the 5 domains what outstanding looks like, what good looks like, what requires improvement looks like, and what inadequate is. And it describes it, and it describes it in the same language that the key lines of inquiry are in. So you can read that and say, yeah, I can see why I got that rating, I can see why they got that rating. And read other reports as well. Look at other... I know the tendency might be to just go and look at other orthopaedic hospitals, but actually read them all. Because the more you read, the more you'll see how so-and-so got an RI, and yes, I can see why that. Because what one trust gets RI for might not necessarily be what another trust gets RI for. So you might think, that's great, because I fixed all of that over here, but over here something else is going horribly wrong, or whatever. So just make sure you're covering all the bases, and by reading round, that's a good way of actually getting your brain into that. Okay.
Thank you, yeah, thank you.
Any other questions from anybody?
I have one. I can see where the direction of travel that you're moving to, but it seems to me that there's a bit about building that relationship, building that intelligence, and I guess there's a little bit of a transition time associated with that before you move into that. So I was just interested to learn sort of how you're going to get that intelligence so that you can be providing that level of assurance on some services in the immediacy of perhaps the next 6 months, really.
That's a really, really good question, and we've kind of started that process now. So Yvonne has started to sort of build some of those bridges. We're piloting a lot of the work. The insight models are building up slowly. We've gone for a sort of a slow, gradual, building it up, getting it better, rather than a big bang approach. We started to build some of those bridges with some of our stakeholders. So it's going to... Me personally, I envisage the next year or so will be a transitional period where we try and build these things up to a position where we want them to be. So this cycle of coming every 2 years or every 3 years, it might take us a year to actually get to a position where we're on that, I don't want to call it a treadmill, but we're on that process. But we will get there, and I think although this was out to consultation and we can't publish the results of the consultation because of the election, we think 99% of what we're going to do is this. And my view is, and I think Bev is the same, is let's be quite pragmatic about this and let's crack on now and let's start to do that now and get those things in process, which is great because that helps us both really then, doesn't it? Does that help? Yeah, lovely, thank you. Is there anything else you wanted to add, Yvonne?
No, I was just going to say about the new model that we're using, Insight, is our tools that provides us with current data about your trust, so that we've got it there to look at every day if we want to, you know. So that's quite good. And combined with the monthly meetings that we'll be having here, not just the meetings, I'm coming out to meet staff, focus groups. I want to know what it's like here, you know, to work here. And you'll be seeing a lot more of me. I might not like that, but I'll be here a lot more meeting staff, not just Bev, all the staff, all the units. So that'll be great. I'm really looking forward to that.
Just one more.
Yeah, just a very short one. You mentioned Insight and you mentioned the dashboard. Are those going to be available to exec teams, divisions, or is that an internal CQC tool?
Initially, it can be internal. But I think the long-term view is that we would like to share it.
So we can see how the data feeds into your
Yeah,
insights, so we
yeah.
know which bits you've got from where.
Absolutely. But while we're going through this transition phase that your colleague at the front sort of talked about, and we build that up into something that we're robust and confident with, we won't be in a position to share that. But I think the long-term goal is definitely to share it.
Can I ask one very quick question, last one? How soon after the inspection will we get our report? The time of this is really important, isn't it?
It's huge, yeah. At the moment, the official timeline is 50 days from the end of the inspection to you receiving your report. Part of the reason why we're saying we're going for shorter reports is because we're not able to achieve that, because the reports are just so big. So to give you a feel for that, you will know that we inspected Shrewsbury and Telford back in December, and those reports are now ready to go to our National Quality Panel. The report for Royal Shrewsbury is 140 pages. The report for Princess Royal is about the same. And then there's 4 other reports, because there's 3 midwife-led units and a trust-wide report as well. So you're looking the best part of about 500, 600 pages of text that's been written. It takes an awful long time to do that, to check it, to validate it, to get it to the right position. And we're not helping ourselves, so that's why we want to move to the shorter reports.
Okay. So thank you.
You're welcome.
I certainly welcome the unannounced bit of it, because I actually think, from being in other organisations earlier on with the CQC, I think that brings a little bit of, it's not fur coat and no knickers. You're seeing us how we are. There's that planning. I think sometimes gives us an opportunity to polish things up a little bit too much, and I think we should be seen as we are. So I certainly welcome that. So can we thank